Well, welcome everyone. Thank you for coming to our very first Decriminalization Spotlight. And why I say that, I am Marcy Timmerman. I'm the Executive Director of Mental Health America of Kentucky. I use she, her pronouns. We are a statewide mental health education and advocacy resource here in Kentucky. We're your oldest advocacy organization for mental illness across the state, having started in 1951. When we use the word decriminalization, what we mean is basically we're referring to the fact that our state's jails, prisons, all of those incarcerated areas have become the home of most of our folks with severe mental illness and substance use issues, rather than treatment centers, which is where they really belong. Most of them their only issues are actually related to their mental illness or their substance use. And we know that nationwide, and that is definitely this case here in Kentucky. So we have decided to spotlight some programs that we think, and maybe the programs themselves are not created to do this, but we think they contribute to decriminalization of mental illness and substance use in Kentucky. I happen to be located in Lexington, Kentucky, and that is where our first group is coming from, partially because I think there's a lot of fascination for what they do across the country, and I wanted to highlight their project. So I've got with us the folks from Lexington Community Paramedicine Team here to talk a little bit about their program, what they do, and then I'll be asking some questions later about how you do it and maybe how other folks can replicate the program here. I'm going to go ahead and turn it over to, I believe that's Seth, right, on there, and Maria Sloan. And do you need to share your screen at all?
You don't mind sharing my screen so I can show a presentation?
Got it. Should be working.
Did
it let you do it? All right, we'll add you.
Yeah, hold on.
All right, let's try this. Now we got it. Woohoo.
So hopefully you see a presentation or PowerPoint slide. Yes. I'll introduce myself. There's actually 4 of us in the room. I know there's only one camera, so I'm going to try to do this without killing me. I'm trying to get into not looking at my nostrils. So I'll kind of give you a little rundown of who we are and talk about, good luck, talk about what we do, why we do what we do, how we came to be. And I'm going to turn it over to the detective from the police department who's on our team, and kind of she's going to explain a little bit about what we do, what she does, how she fits in the program, and why it's so important. So a little history about us. A little history about us. We're trying to. We don't have very good presentation equipment, so we're trying to work on that right now. So our process was this. Except now my head's cut off now. Good. So our process was this. In May of 2017, we were awarded a federal grant from the Assistance to Firefighter Grant Program, which is done by the Department of Homeland Security. Our grant was actually $272,000. It's required $250,000. I'm sorry, a $25,000 local match. And the whole purpose of our grant was to start a community paramedicine program in the community. Patrick, Brandon, and myself came over to the organization, to the office in September of 2017. And when we walked over to the office and said, okay, where do things stand? It was quickly realized that we have a lot to do, a lot of paperwork to fill out. Our community paramedicine component of that is overseen and regulated by the Kentucky Board of Emergency Medical Services. K-Beams, we're paramedics. We're licensed through K-Beams. Our ambulance service in Lexington is through K-Beams. Our ambulance service is licensed through K-Beams, and they started this whole concept of community paramedicine. So we were one of 8 pilot programs that were started in the Commonwealth. But I think we're one of the most unique. When you look at what other people are doing for their community paramedicine programs, the other 6 of the remaining 8, the remaining 7 are tied to hospitals working on reducing hospitalizations. Louisville Metro EMS is doing low acuity calls, trying to divert people from using an ambulance to get to a hospital or to a doctor's office. And so we're kind of doing this holistic approach. We started looking at our high utilizers, and when you look at Lexington population of 330,000 people, less than 0.1% of the population. Again, I'll say that again. Less than 0.1% of the population accounted for 9.1% of our ambulance runs. And so we started really trying to delve into why. And so when we went live March 2018, we had a really good list of individuals to go after, to start talking to, try to see what we can't solve problems. And our aspect was making sure they had doctors, making sure they had appointments, making sure they had medications, making sure that they were getting the right care at the right time. In the summer, we got an introduction to a professor at UK, a social worker named is Allison Gibson. And we explained to Allison what we were doing. And the next thing you know, Allison's like, you all are doing social work. A lot of what we were doing was social work. We weren't doing a lot of paramedic stuff. We were doing a lot of navigation. And she advocated for us to become a practicum site for the College of Social Work. And in the fall of 2018, we started with two students, both in the master's program. It was great. That summer of 2018 was a busy time. We quickly realized that we were calling on a couple of police officers regularly, because we recognized that a lot of our high utilizers oftentimes would be police department high utilizers. And so we went to Chief Weathers, who sat down and listened to us pitch this idea of, adding a police officer to our team, and listen to the reasons we felt were so important. The reality was having that police officer, we're going to be able to navigate together the individual, as opposed to us working on an individual going in one direction, the police department going in another direction. Being together, working together helps us really navigate and advocate for those individuals. And he was so phenomenal. He sat and listened to us for about an hour, and without hesitation said he thought it was a wonderful idea, with one caveat: we needed to find somebody to do this. And we were quick to find a detective to come over and work with us. And through time, we've evolved, and we now have Detective Kristen Smith, who's on our team. And she's really great because she brings a social work background, and it's a great mentality, a great mindset to have with us. So as I said, when you look at our population of why we're doing what we're doing, the numbers anywhere between 35 and 43,000 people in Lexington are over 65 years of age. Yet in Lexington, the fire department in 2019, we transported 31,500 individuals. Of those individuals, there were 13,000 that were over 65. So they represented 41% of our population, of our ambulance population, if you will. And so we really saw this need to be able to try to navigate those individuals, those high utilizers that were, didn't maybe have the resource to go to the doctors, or, didn't necessarily have the family support for one reason or another. I didn't know, I think with the advent of our, our healthcare and our insurance system now, I think it became, we're now really truly consumers, and having us, acknowledging that we could be having a conversation with our doctors. I harken back to my grandparents. The doctor said this is what you need to do. Never a question. You did what the doctor said, and now the question is, are there other alternatives that's doing the most expensive thing to be done? And can we look at something alternative, and getting the patients to advocate for themselves? And it's been fairly successful. We, it's very hard to quantify or to look at the impact that we have on an individual. It's very hard long term. One of the things that we can do, though, is look at somebody's demand on EMS, and look at the EMS demand. The next slide, when you look at 2013, we made 33,500 ambulance runs. And between 2013 and 2017, which is 5 calendar years, we had grown 44%. We've gone up to over 48,000 runs. And it's really easy to look at and go, we had less than that 220 people. To go back and look at those 220 people and see the decrease in demand that they've had. To look at the overall impact that we've seen in terms of run volume. Every year since we started, we've had a negative growth in ambulances. And why is that important? To staff an ambulance in the city of Lexington, it's not just two people. You're looking at 12 personnel, 12 firefighters, and that costs almost $1 million a year to staff. So not having to add that ambulance every single year is a significant impact on the budget, significant savings. So on the flip side, when you look at the impact that we're having on individuals' lives, anecdotally, when you look at these type of programs throughout the country, you see a large impact on the insurance when a community paramedic program involves a client. But it changes, the costs are changing. Instead of having a high expenditure going to the emergency room, what you see is a high spike in expenditure that's going to a primary care, usually with a lot of laboratories and and some x-rays or maybe a CAT scan. You see that expense really up front, but over the course of the next 18 months, you see the costs significantly decrease because those individuals are now getting the help that they need, the care they need, the right care that they need. And it's a very efficient mechanism to get that care. And so they're better, more independently serving their lives. We evolved with the advent of the epidemic. We were presented an opportunity to apply for a grant through the Department of Justice. And this grant was to provide a social worker for us. We saw a continuing demand on the opioid epidemic. And we looked at how can we respond to that. So one of the things that we've done is look at models like Huntington, West Virginia, or Corning Township, Ohio. And when you look at what they've done, they are taking a combination of individuals. In Huntington, it's a paramedic, a police officer, a drug counselor. In Ohio, it's a police officer, paramedic, and then you have a mental health professional. We look at what we can, and I apologize, I'm getting notes that my internet connection is unstable. I apologize if I'm cutting it out. Feel free to let me know if you've missed the point that you'd like clarification on.
You can reiterate who the team members are. That's all we need to know. Like
okay. And so when you look at different agencies, they've done it a little differently. We felt here in Lexington, we felt hiring a social worker is imperative. But when we visited some other agencies, we didn't feel that the police officer was an absolute must to be able to function. And so we've gone ahead and moved with doing this. And we were able to hire Maria Sloan, our social worker. And what her role is to follow up on overdoses. And I'll show you a slide in a second as to why it's so imperative. Our numbers of people that we have overdosing in the communities continue to go up, sadly, because of COVID. And we were able to get the grant renewed, and we're going to actually hire a second social worker starting hopefully in the next few weeks. We're actually interviewing currently. And so we're going to have a social work team to be able to focus on the substance use issues that our community's dealing with. Being able to meet them where they are is imperative. Because it's so unique. As I said, in 2017, we had over 1,600 overdoses. And in 2019, we really started to see those numbers significantly impacted. Maria was employed starting in 2019, early 2019, and we really started to see a significant impact with the number of individuals that were suffering from, overdoses. And we were really going in the right direction. The community, having the number of fatalities that we had, was going in the right direction. It was really going in a good choice, good direction. Now, still a lot of work to be done, but definitely the trends are looking good. And then COVID hit last year. And sadly, when COVID hit, the number of overdose individuals that were presenting were back to 2018 numbers per day. We saw significant impact starting in April, May, and towards the first half of June. Towards the end of June, you started to see those numbers kind of trend back down again. We started to see a little bit of a spike recently in the last few weeks. And we hypothesized that a lot of that has to do with the stimulus money. People have been given an infusion of cash. And so what we're dealing with is individuals that are many times dual diagnosed, and working with them to make sure that they're getting the right care that they need. getting into treatments or getting engaged to harm reduction, needle exchange or syringe exchange programs, getting naloxone, Narcan in the home, anything they can do to be safer. Today, they may not want services. Today, they may not want treatment. But if you can kind of keep them alive, that hopefully in our next, maybe next week, next month, they're going to want some help because they've realized that there's other alternatives. So moving forward, we've been really blessed. Recently, the hospitals saw the value. We work very closely with case management teams from the hospitals, and they help offer some funding to keep us going financially, how we're staffed and to keep us going. So we didn't have to shut down a year and a half ago. We are now looking at how we can impact policy, at the local level, at the hospital level. Some of the things that entities, programs do by flexing a little bit makes a big difference to being able to serve a client. There are simple procedural things that sometimes people don't recognize, and it can make an impact on that individual. And then we're working always to continue to analyze our stats and our numbers, looking at trends. We hope to look at the best and the greatest things. We're in conversations. There's something called the OD map that looks at ODs in real times and maps them on a map, just to be able to look at trends and where problem areas are. And that's something that we're looking at a conversation this week with them to see if we can't incorporate the information. We're doing a lot to try to impact a population that I think oftentimes doesn't have a voice, it doesn't have an advocate, and trying to be that voice or teach them to be their own voice sometimes, just so they can speak for themselves and advocate for the needs that they have. I think one of the neat things that we have, and I'm about to turn this over to Detective Smith, I think having this partnership with the police department, the fire department working together, working on these individuals brings a unique perspective because, she brings, Detective Smith will bring a bunch of the legal stuff. Our Maria Sloan brings a lot of the mental health experience. She brought 20 years of mental health experience to our team. And being able to have those conversations with an individual, make sure that we're serving that individual the best way that we can, and advocating for them to get the stuff that they need, the services that they need, and the treatments and those types of options that they may not know about. So I'm going to slide away from the camera, and Detective Smith will slide up front and see if we can't have it. Joe, continue on with the presentation. Okay.
Thank you so much. It's wonderful.
Good morning. Let me slide up a little higher. I got to make myself a little higher. So good morning. Good afternoon, everybody. My name is Detective Christy Smith, and I've been with the Lexington Police Department since September of 2003. So this will be my 18th year here. In 2014, and I think this is important to tell you why and how I made it to where I'm here today, sitting in front of you. I worked a case that really changed the course of my career, and it involved the murder of a vulnerable adult and the severe neglect of his siblings by the parents. And in working that case, it kind of opened up my eyes to investigations involving the mentally ill, the severely disabled, and the vulnerable adults in our community. And one thing that I realized is that not only did the young man who lost his life have no voice anymore, but neither did his siblings. So it very much took the voices of many of us in the community to stand up for them and to advocate for them and to bring improvement into their lives and support them. And through that, it also made me realize that vulnerable adults, they make great victims of crime. They are vulnerable. They have oftentimes limited resources even to get to court. They have limited resources in terms of those willing to advocate for them. They really come from a place of disadvantage. But it's more than just that. It is also those in our society who are homeless, those in our society who are mentally ill, they have, by virtue of where they are in life, can oftentimes provoke an enforcement by, or a response by law enforcement, jointly sometimes with the fire department, both, one maybe without the other. So throughout all of that, I have learned that it takes a lot of things to make a person, or to help a person come out of the place that they are. For example, if I am called to one of the restaurants downtown for a disorderly individual, and that's probably how it's going to come out over the radio. In the past, maybe when I first came on 18 years ago, and let's face it, policing has changed a great deal in 18 years, even when I first came on. It's much, much different. Back then, the person probably would have been arrested for criminal trespass, or it would have been something like that. Disorderly conduct, maybe public intoxication, maybe shoplifting, theft of services. Those are kind of more of our common misdemeanor offenses involving our hyper-utilizers of services, particularly on patrol. So that acute response that you get when you get a patrol response would have probably been jail. At this point, now in our community, we have many, many things available to us that we haven't always had. We have the cooperation of our legal system. We have training and education offered by the police department and other community partners, just like we're having today. This is a very big part of decriminalization of the mentally ill. This is it right here. This is one of it. But now we have other options and other tools so that a criminal charge that's probably going to stick with the person for a very long time. Limited resources probably mean limited availability of an attorney. It may mean limited availability and options to get to court dates. All kinds of things come from that one simple arrest that can usually drive a person even further down from where they are. So we have developed partnerships and additions to our legal system that have become quite valuable when we're talking about decriminalization. We now have drug court. We've had that for several years, but drug court is hugely important for those with substance abuse and addiction in terms of keeping them from repeated arrests. And it is probably one of our largest tools, especially for misdemeanor offenses. Drug court is very valuable. We have mental health court that we didn't always have. Mental health court is hugely valuable. Oftentimes court mandated appointments with mental health providers, which means usually medication compliance, which usually means more stability for a person, which usually means less interactions with the police department, which usually means higher functioning in their day-to-day life, more stability for them. Mental health court is one of the best and most valuable things that we have. Another one is guardianship court. I know myself and firefighter Brandon, you can't see him, but he is right here to my left. We have, and I often testify in guardianship court for individuals who are finding themselves in a place where they can no longer manage the day-to-day functions of their life without the assistance of others. And what I find is without court-appointed assistance or someone who is willing to step up and have that assistance provided, people need to secure their needs, and they are most likely willing to do that however it happens. And usually that opens them up for victimization and many, many, many other encounters with the law enforcement and police and the court system. So guardianship court is, and not only that, but oftentimes those who need assistance, they're not on their medication, they're not attending appointments, oftentimes finds them in trouble in places that, are not healthy for them. So guardianship court is a really good option for some, not all, but it is there for those that can benefit from guardianship court and having someone step in. Another one you won't see very often is KCPC, and it's the Kentucky Correctional Psychiatric Center. And I'm a big advocate in this because oftentimes we have, there are mental health elements in some of our criminal cases. And if that is there, then I think that becomes very valuable to both, due process when a person goes to court and their case is heard. So I oftentimes use KCPC, and I rely on them a great deal. I think they do a very good job. But those 4 components are very, very, very important to me when it comes to decriminalizing some of these offenses and interactions with the law. One other thing that I want to tell you about is, you may not know, but the Lexington Police Department does a 40-hour crisis intervention team training. And myself and Sergeant Brian Martin are the co-coordinators of that. As of this year, we have about 95% of our 600 plus member agency has been trained in crisis intervention team training. And that training teaches officers how to, a little more in depth, how to interact with someone in crisis, whether that crisis is due to an intellectual disability, developmental disability, or a mental health crisis. So some of the things that they learn in that class that before might have been deemed criminal behavior, if it was a disruption or walking down the street, maybe they were hallucinating or talking to themselves, rather than seeing that potentially disruptive and as a criminal behavior, now they recognize that to be what it is, and it's potentially a mental health crisis. So in the past, rather than jail being the only option, now there are other options, and officers have learned to critically think through that. And is this a mental health crisis? Does this person need intervention now? Do they need the assistance of Nuvista? Or, we have learned to integrate this training and provide a better response to our consumers in the community. It also makes a better relationship with the officers and our consumers in the community. There's a trust now, or there's at least not as much of a fear that if someone in crisis sees a police officer, they don't automatically think, oh no, I'm going to jail. And now it might be the last time this officer interacted with that person and they were in crisis. There's more of a trust now because the last time they got help and they didn't end up in jail. So the encounter oftentimes starts out much, much more positively. Our officers have learned to better articulate what they see, what they hear, what they observe when they're encountering individuals on calls, and they're looking for things that historically we did not know to look for. That saying, "You don't know what you don't know." I think that's huge here, because you don't know what you don't know until you start learning, and you start learning that some of these things are not just criminal behavior; they are just elements of a mental health crisis, and I find that to be very, very important. I kind of touched over some of our social services that we use, but adult protection services, officers are learning to use some of these outside agencies and partners to come in and understand that it doesn't always have to be the police officer's responsibility. We can rely on other schools of thought and other houses to come in and try to help us work through a call. So adult protection services is a huge one. State guardianship is a huge one. There is absolutely an open door policy with state guardianship to call them if we know a person has a guardian. We're able to reach out to them and let them know that perhaps their person is experiencing this, or we know they've been experiencing a crisis for a week. And maybe there is no one else to relay that information to state guardianship. So we have come a very long way in paving those relationships with some of these agencies that we use every day. I mean, we all have a common goal, and that's to help an individual. So we're just learning how to really use those partnerships more efficiently now. So I told you, this is paramedicine. So I think it begs why do we have a detective with paramedicine? Because there's nothing about detective in paramedicine. There's nothing about that. However, we've talked about a lot of individuals make great victims of crime. I have officers, I know last night, I get phone calls 24 hours a day, 7 days a week, that for officers who are on calls, and they say, we have this person, do you know this person, or this is the situation at hand, how would it be best to deal with this situation now, and can you pick it up tomorrow? I already mentioned, there's usually when police and fire are on the scene, it's for an acute fix. It's an acute end to what's happening right now. The thing that's most valuable about this particular unit is that we do have the hours the next day to come back and follow up and go to that house. And try to figure out, did they follow up with their therapist like they said they would last night? Were they able to get an appointment today? Why weren't they able to get an appointment? Do they have minutes on their phone to get an appointment? Do they have electricity to charge their phone to get an appointment? Those are all things, little things behind the scenes that the four of us collectively can work together, and we can invest the time the following day to follow up and make sure that those little bits and pieces behind the big scheme of things get put into place, so that these other crisis moments or these other critical moments can be managed better by the individual, as opposed to resulting in a call for service from police and fire. So I think we bring with it more continuity and longevity, and we build relationships with a person. And the other thing is, those people often call the four of us as opposed to 911 for a call for service. So they know they're going to get one of our four faces, familiar faces that they've seen, as opposed to an officer or a paramedic that has never met them before and that to retell their story. We're already very familiar, and we can pick up that. We work with hospitals and other organizations, like I said, to secure services where the gaps exist. It is not outside of our realm to go to a doctor's appointment with someone, to help them make a doctor's appointment, to help them seek out a practitioner who would serve them better. So we really sit down and try to problem solve and make that success for them. They need to be successful. The more successful a person feels, the more successful I think that they become. And we try to make sure that they know that they matter. And one last thing, I absolutely believe in advocating through the courts for alternatives to imprisonment. Sometimes, there are some cases where it is appropriate. There are many cases in which it is not appropriate, and there are other things out there, other alternatives to jail and prison that are better. And then we go back to KCPC and how valuable a role that is. If someone does commit an offense that requires a charge or a criminal investigation, we can revert back to KCPC and move forward together with defense attorneys and prosecutors, all at the same time, all at the same table. Offers are, I think, when the Commonwealth attorney or the county attorney starts to look at cases, since they have mental health court and guardianship and drug court in their levels, we have more options. We have more things to use other than probation and fines and court costs and those kinds of things. So this is our attempt to decriminalize mental health and offer more solutions and brainstorm. I hope that it continues to grow, because I do think it's valuable. Maria plays a very valuable part to all of this. A lot of times people don't like to call the police and fire department over something related to narcotics or substance abuse. They think they're going to get in trouble. We've tried to make it so that if it means the difference between saving someone's life in an overdose and calling the police because they're afraid that if they call the police for help, they're going to go to jail because someone there had an illegal narcotic, we have made it so that that is not the case. You call for help, and if there is paraphernalia, it is not charged. We have Maria, who has this amazing booklet of outreach and addiction supports and resources that she has readily available. We give those to police officers working the street in our downtown bike units, so that they also have something to hand out to families in need, to some of the individuals that they interact with. So we try to make it so that that fear of getting in trouble because they may have a needle or maybe they have some other item that would be considered paraphernalia is no longer a fear. And if they need help, they can reach out for it. So I think I've included my phone number. This is my cell phone number and my email address. You all are more than welcome to copy it down and then reach out to me if you have questions, comments, concerns, suggestions. I would love to hear them. I would absolutely welcome your feedback. But I guess I'll turn it back over to Seth.
I'll turn it I'll turn it back over to Marcy. I think you had indicated that let us have some time for a presentation and answer any questions. And I think the four of us are sitting here waiting anxiously for any questions that anybody would like to throw at us. And so I'm going to stop sharing my screen. How about that? And what else do I need to do?
No, you're fine. I'll remove the spotlight now so folks can stop seeing just your face too. So thank you all. That was an excellent presentation. One thing I don't know that was clear is how you're funded. I don't know if you can talk a little bit about that, Seth, or if you want me to do that, I'm happy to.
No, so yeah, Patrick just said we're not. So I will start with the easy one. The easy one is Chief Weathers on the police department has identified this as being an extremely valuable position. So they have he has made this position as a permanent position. Maria Sloan is funded through a grant. We just got a renewal, so she'll be going for another 3 years, being paid for by the federal government. And we weren't sure we'd get this grant. And last summer we started arguing that we cannot let her go. She is one of the strongest glues that make this team to go together. As for Patrick and I, how we are funded, it is city money, but we're not permanent positions. So basically, we being here has created vacancies on our fire trucks. So how they solve that is they backfill our vacancies. When we're not there, they'll put in an overtime body in our spots. And I believe the mayor has said in her latest budget address, she said that we are funded fully, which makes me believe that they're going to keep doing the overtime way, continuing on next year. And it sounds really awkward to be willing to pay overtime, but with an overtime person, it's not always needed because our staffing doesn't always require overtime. And additionally, having overtime means you're not paying, pension costs and benefits for an additional person. So right now they kind of try to toe the line on hiring new people within the city. And so one of the ways that we are funded is backfilled overtime, but the city pays the city is basically paying for us. I think there's a little bit of hospital money left over, but the city is going to keep us going for the time being. So.
Thanks. And for those who are not familiar with Lexington, our paramedics, our firefighters are together. They are cross-trained in both of those. So that is something that we do locally. It's somewhat common in large metro areas, but not necessarily the case in a lot of rural Kentucky. So I just like to clarify that. It was kind of news to me when I met Patrick the first time. So I was like, oh, that's how we do it here. So just a factor there. Does anyone else have any questions or anything you wanted them to talk to? They're a great group. Kind of have a question for Maria, actually, if she doesn't mind. I know you guys are playing musical chair now, right?
I got to stand up because I'm too short.
I totally get it. So am I. So thanks for being on, Maria. I had a couple of questions for you about what you do as far as substance use and overdose work. Folks were wondering kind of, I've gotten this question a lot, not necessarily on this webinar, but in general, like what can we do when we find someone who is in a situation where there's a substance use issue? I didn't know if you had any like experiences that you've had that you wanted to relate, like some way that the community paramedicine team really is able to intervene and maybe keep someone out of jail specifically.
So typically we get referrals through our own system, but too, we take outside referrals for anybody that has family or themselves that are experiencing substance use disorders. And we just typically go out. It's person-centered. We are person-centered. That gives us the ability to sit down and talk with the individuals and the family, because we know and realize that substance use disorders affects everybody that's involved with the individual. And so we try to offer as many supports as we can to family as well as the individual themselves. And so I do have I can send you my information for anybody that's in the Lexington area that would like to have our information so that they can make a referral. But we have stories of success. They are sometimes far few between, because, building that rapport is the most important thing for us, and building that trust. Because oftentimes individuals that we serve for substance use or mental health disorders, that trust factor is very important, and they have to rebuild that people are there to support them, and people are wanting to come back and help them, just to be there. And so sometimes we really get a lot of that. I didn't know that you all did this. I'm so thankful that you all come back out to check on me. And just building that rapport is the most important thing for us, because we oftentimes know and see that a lot of people have burned a lot of bridges, whether it be through mental health or through, substance use. And so once we're able to really get to know and work with an individual, we just sit down and we discover what's going on. What's your story? Let us know what's going on so that we can see how we can best serve you. And that, if that means pulling in Christy for the justice aspects of it, looking at that individual's background to find out what's going on, if they're on parole, who can we talk to, and just trying to navigate that individual's people so that we can start having conversations and being on the same page. So that we can provide that service that is needed, so that all areas of that individual is addressed, whether it be the mental health aspects or just the substance use, or whether justice involvement is there. And I think one of our most recent cases that we worked with was a family with Casey's Law, because we have an advocate here in the Lexington area, and being able to see that process work for the family and the individual was something that we learned as well along the way. But being able to learn how that process works and getting the individual to treatment and seeing the family have some sense of relief after that individual's gone, and stuff. And so, we're learning as we go too, still, always. And so, yeah, that's
a good answer. Thank you so much for that. Yeah. And there are lots of resources available. Obviously, you all folks can always reach out to MHA Kentucky. I'm always happy to help folks find something local. If it's right for you guys, I send it over. So I try to be a better gateway than just wide open to your phone number. So sorry about that. Folks who don't know about Casey's Law, that is actually a law where family members can petition to have someone entered into treatment through the court system, and they have to pay for it, though. The family or an private insurance can pay for the treatment. So it's a way to get someone in substance use issues into treatment. So it's not always the best way, but it's a way, and sometimes it's what you got to do. So yeah, that's probably why you hadn't seen a lot of it, right? It's a very kind of a last resort kind of thing for most families. So, yep. Any other questions or comments from anyone on the webinar? Patrick, do you want to say hi?
Hi. It took away my chair.
That's all right.
Well, I just want to say thank you very much. One of the things that we've learned is it absolutely takes every single one of us, no matter what we have, to do this. It takes, we hear all the time that it takes a village. It does take a village. So we're absolutely honored to be able to do it. I think one of the biggest things that I have learned, it's good. One of the biggest things that I have learned and that we try to teach is, everybody, that's my badge. Mm-hmm. And several years ago, I got that with 2009 here for Lexington, but I had worked in Mercer County for several years. I worked for the Sheriff's Department. I worked as a paramedic. I was a volunteer firefighter. And I worked in Philadelphia for a little while, and I was very proud of that badge, but I've grown to realize that I can have all the skills and all the training in the world, but I can't utilize any of it unless I have somewhere to work. And that badge gives me not power, but it gives me an opportunity to advocate. It doesn't belong to me. It belongs to the city. It belongs to the people that we serve, and it belongs to whoever called today. And so whoever needs me and the skills that we have today, at that moment, at that minute, that badge belongs to them, and however we can best serve them is what we have to do. So having an opportunity to be a part of this team, it's multidisciplinary. It takes every single one of us to sort through things that didn't happen overnight, that happened over time, and it takes a minute to unravel that and to figure that out. So having the time to be able to do that and having the honor of being able to serve in that way has been one of the hardest but most rewarding parts of my career. So it takes all of us, and we really appreciate every single one of you being able to look at, not that a person shoplifted, but why did you shoplift? What did you do? Why were you trespassing? Not that you trespassed. Sure, you did, but why? Not that you stole something, but why did you steal it? Was it milk and formula, or was it diamond rings? Was it mischief and attention? Was it feeding a necessity, or did you have the ability to recognize that was right or that was wrong? And so this gives us an opportunity to look back through lots and lots of records to see your story, and then go sit down with you and hear your part. Because if we can't see it, and if we can't sit in your living room and smell what you smell and see what you see and hear what you hear, your living room, if it's in a house that costs $1 million, or if it's in a car, or if it's on the street, this gives us an opportunity to sit in your space and to hear your story, and to look at a past record and figure out where something didn't go right and how we can best serve. So we couldn't do it without you all in the community, and it's an honor to do it. So thank you.
Thank you for that. Couldn't have scripted it any better. Not that it was scripted, I'm clarifying that. Thank you all very much. This was a great presentation. Already getting lots of thanks, lots of kudos, and thanks for all that you do. I hope all 4 of you and the whole team knows how much we appreciate you from MHA Kentucky, and as a resident of Lexington, how much I appreciate you. We will be following up with some additional decrim webinars. Next Monday is Kentucky CIT. So we're going to sit down with Denise and Ryan and have a talk about what that program is more in depth. You heard it mentioned here in decriminalization, and we're going to talk about it statewide. There have been some great increases in that program for this year. And let's see, and we're going to take a little bit of a hiatus during May as Mental Health Month, unfortunately, because my May got full, but we are going to pick up with some more with the drug courts and the mental health courts, and talking about the mobile outreach teams and other groups. So lots more to come on this series. It's going to hopefully be a whole year long. So lots more to come, but thank you all for kicking it off and getting us started so well. Everybody have a great day.
Thank you all for having us so much.